Thanks for inviting me to speak this morning. As a cancer nurse of substantial years of maturity, I can reflect on a time in the late 80s when a 4-bed bay of the medical oncology unit at the Royal Melbourne Hospital was opened as a day oncology unit. It seemed to be a bold move at the time and was new territory for us. Low activity is often the case when new services and innovation are implemented, and I remember the luxury of time that we had to spend with patients. It was vastly different to the frenetic pace that most day oncology units experience in the current era. The changing landscape is multifactorial and attributable to an increasing incidence of cancer, clinical trial activity in cancer, and the emergence of an increasing number of chemotherapy options for multiple cancers. This slide takes us to 2015 only, yet we know that in the last 3 years there's been a huge increase in the number of drugs that are being developed and released for use. Improvements in supportive care medications, particularly in the management of nausea and vomiting. I think the introduction of 5-HT3 antagonists in the 90s I remember as a game changer insofar as changing the doses of chemotherapy that we were giving patients, moving patients from the inpatient scenario to the ambulatory scenario. The use of growth factors to shorten neutropenia associated with chemotherapy, and technological advances such as central venous access devices and ambulatory infusion pumps. This has contributed to a shift in increasing numbers of patients being treated in the ambulatory setting, which is where most of the growth in treatment delivery is now taking place. In the modern era, peak national cancer bodies such as COSA and CNSA provide a beacon for organisations providing cancer services in relation to ensuring safety and quality and in administration of cancer therapeutics. The COSA chemotherapy medication safety guidelines are prescriptive in their expectations across the disciplines, and a summary of recommendations are provided to guide services in establishing quality and safety around the delivery of systemic cancer therapies. Evercube provides a one-stop shop of the research data generated across the world, distilled down to into something that can be used by clinicians whether a patient presents to a large metropolitan hospital or a small regional centre. It has been embraced by most organisations, as the previous speakers have highlighted, even if it is to source their own internal protocol manuals. Internal protocol manuals are sometimes required to meet the need for drugs that haven't yet made it into Evercube. And if I think about the compassionate access schemes such as pembrolizumab in lung cancer, that would be an example of a local policy meeting a need that Evercube hasn't yet met. At Austin Health, where we have recently implemented the Oncology module of Cerner, Evercube was the primary source of protocol development and within that system, and it links to Evercube algorithms for toxicity assessment and revisions. Jean has talked fairly extensively about educating the workforce, so I won't dwell on that too much. But I suppose from an Austin perspective, ADAC has certainly been great as far as decreasing the need for us to use our own resources to build courses. It does become problematic to get nurses through those competencies though, particularly in the inpatient areas. As I said, most chemotherapy is given in ambulatory space, so nurses working in inpatient wards struggle to have the exposure to giving chemotherapy to maintain their competency. One of the approaches that we're looking to at the moment is to quarantine some EFT in our day oncology unit that we will constantly rotate nurses from the inpatient wards into on a periodic basis. And I know that model exists at some of your organisations already. Apart from preparing the nursing workforce, the ADAC Module 1 also addresses safe handling for the non-nursing health professionals in your organisation, and at Austin Health we utilise this for educating our PSA staff, and it's even included in the orientation of the intern medical staff each year and delivered by our clinical nurse education department. The more recent revolution, I think Graham coined the phrase revolution, is the delivery of cancer treatment in the non-cytotoxic chemotherapy treatment options. This graph depicts a snapshot at the Austin Day Oncology Unit over the last 5 years. I just did a snapshot of May each year, even though the graph says January, it was May. And the trend shows a fairly dramatic shift away from cytotoxic chemotherapy alone. It's only actually 40% of the work that we do in day oncology at the Austin now. I think, the ONJ is a big clinical research centre, so this may not be reflective of everyone's centres, but it made me wonder, are we the barometer for the future? And I think possibly we are. Some of our non-cytotoxic growth has been around the implementation of the bone marrow transplant program, and that explains the increase in CVAD and supportive care patients that you'll see. But as you can see, the yellow bar, which is immunotherapy alone, has grown significantly, particularly in the last year. And there's been a less dramatic growth in chemotherapy and targeted agents alone. You can't really see so 17 and 18, you can't really see it because it's such small numbers, but there's also an increasing emergence of immunotherapy and chemotherapy in clinical trials. We've got currently 20 trials open at our centre that are looking at combined chemotherapy and immunotherapy. So I think that's going to open up another new frontier for us as cancer nurses, educating patients about those combination drugs. Apologies for another slide that's 3 years old. However, as you can see, I hope you can see it. It's a bit faint, this slide, but targeted agents and immunotherapies are really the focus of drug development across a number of tumour streams. And there are a number of implications for us as cancer nurses and the other health professionals in the room as far as how we educate patients to optimise self-management throughout their treatment, how we partner with other healthcare professionals who they may come in contact with, particularly ED and their GPs, and preparing the cancer workforce to care for these patients. Within our service, patients who present for chemotherapy are given a one-to-one education session prior to starting treatment, usually sometime in the week before. When targeted therapies and immunotherapies were first introduced, due to the sheer volume of patients and limited resources, and a perception that the toxicity profile was not quite as acute in onset, I guess a decision was made that we wouldn't give these patients necessarily a dedicated pre-education session, that they would receive it in the chair on the first day of treatment. And depending on the knowledge base of the nurse who was looking after that patient, which really at the beginning of these agents, sometimes that knowledge base was not as good as it could have been, and the competing needs that the nurse had with their other patients they were looking after, the level of that education information to patients varied. The issue of nurse, pharmacist, medical staff education has been addressed quite well by industry, particularly in the immunotherapy space. I think most of the big drug providers have really done a great job at educating the workforce. And recently ADAC have added an online immunotherapies course, which is a 3-module, similar to the ADAC, it's just an extra module for immunotherapies. It's approximately 6 hours of learning, and that's certainly something at our centre that will be, I'll be expecting all the nurses in day oncology to complete. Likewise, the patient educational resources on Evercue were scant for some of these drugs because they weren't on Evercue yet. And again, industry-sponsored patient education materials were very good, and that's what we've been utilising for the most part. Our broader experience with immunotherapy agents has highlighted the gap in the approach that we had though. So to meet this education, we implemented a group education session earlier this year for patients on immunotherapy drugs. Topics that were included in these group education sessions that were a departure from the traditional chemotherapy education included the side effect profile, which is quite different, the precautions around waste management. Obviously they're not cytotoxic, so we didn't need to educate patients in that regard, and remembering that a lot of the patients who are on these immunotherapy drugs may have previously been on chemotherapy, so they've got that background knowledge, so we had to change their mindset as well, and sexuality and intimacy issues. Patient feedback from the dedicated pilot was great. Some of them wanted to know if they could come to the next one. They sort of saw it as a quasi-pilot support group. But the resource that we had that was dedicated to running that program finished, so we've tried to incorporate it into business as usual, and with a lot of those improvement projects we found that patient subscription to the group education sessions fell off a bit. So we've reviewed that, and just to try and improve patients attending those, we're looking at cohorting the days of the week that we give immunotherapies and running the session on one of those days. And we're setting an expectation with patients from the outset that they will come to a session. So it's more of an opt-out for them rather than an opt-in. And we're hoping to see that patients will come along to those sessions. Most centres provide a medical alert card. I'm sure most of you have got these that you give to these patients. There's two here. The one on the top is our old one. The one on the bottom right is our new one that we changed about 2 years ago in response to a couple of incidents where patients presented with diarrhoea on immunotherapies and weren't optimally managed as we would have liked. So we've added GI symptoms to that card, but that's really the tip of the iceberg as far as patients presenting to ED. There's many other things that they could present with as well. So I think educating your patients, giving them those the industry-sponsored cards is really important so that they're very aware of what they need to look out for and act on. Common across most health services that I've worked in is a friendly antagonism between the emergency department and cancer services staff. I think patients become precious about how the emergency departments manage their CVADs when they attend. We find that they never give them their antibiotics in a timely manner when they're febrile neutropenic. At the end of the day, EDs are not great places for patients to attend, we know that, but they do have to attend there from time to time, and to their GPs as well. With new agents, ensuring ED and GP colleagues have the information they need to manage appropriately is as important as ever. And above and beyond side effects, educating staff around the drugs and clarifying the misunderstandings, such as the patients don't need to be on cytotoxic precautions, can be very helpful for staff working in ED, and it removes the conflicting messages that patients might get. Again, it's very disconcerting for patients to receive one message from the cancer staff who are looking after them and then present to ED and get a different message. Many of the targeted agents in immunotherapy, I've talked about the resources, and I know that Sally's going to talk more about the symptom and urgent review clinic, so I'm not going to talk too much about that, but we do have that model of care at the Austin, and we're utilising that a lot, particularly with these new agents. In relation to GPs, another innovation that we've implemented this year is a GP summary letter. So every patient who starts chemotherapy in our unit gets sent a summary letter that has a list of the more likely and significant side effects that the patient might experience, and it's got a link to the Evercue regimen as well. We implemented that about 2 months ago, and we're just about to do some surveying of GPs about their experience of receiving that. The ageing population, I think this is a really significant thing that we are facing. Cancer incidence increases with age, and the number of people living into older age groups is increasing. Undoubtedly, we're now offering treatment options to older patients, and that's a trend that will only increase. I'd like to introduce you to Little Miss Sunshine. As this patient came to be affectionately known, she's the mid-octogenarian diagnosed with non-Hodgkin's lymphoma late last year. Prior to the diagnosis, Little Miss Sunshine had been in excellent health, living independently in a rural community with many friends and participating in local activities. With an incredibly supportive family, friends in the local community, and particularly an enlightened and determined daughter who had good health system navigational skills, Little Miss Sunshine completed 6 cycles of RCHOP in March and continues to live independently at home. However, she's probably not a true representation of the elderly patients who we will encounter, who will come to us with comorbidities, limited support, cognitive impairment. These patients need a healthcare system that can respond to their unique needs, including a workforce who is educated around comorbidities, assessment and management of symptoms that may be cancer, comorbidity related, or both. We need flexibility in care delivery models, whether they be in the patient home or care facility, and we need true assimilation of the family into the nursing care, acknowledging the demands of caregiving and working as partners with caregivers. Managing the increasing workload. It's a significant challenge for us at our centre, and I'm sure that many of you in the room share that problem. Currently, we're undertaking a large piece of work to ensure we are positioned to meet the growing demand with a physical resource that is currently at capacity, working in terms of a Monday to Friday service. Some of the questions that we are grappling with include subcutaneous routes of administration. An increasing number of therapies are now available via subcutaneous routes. However, there's a financial disincentive for us to move patients to subcutaneous routes of administration because we don't get any money for them. So at Austin, unless there's a clear clinical benefit to patients by giving them subcutaneous routes of administration, we haven't gone down that path. I understand at the DHHS level that there is currently a body of work looking at subcutaneous routes of administration, and so that's something to look forward to. We have implemented the subcutaneous immunoglobulin program, so that has provided us with the opportunity to move some patients who are coming on a monthly basis for fairly long, lengthy chair periods into their home, which has created some capacity. HIF options. Currently our HIF service is a general HIF service with no specifically trained cancer nurses. Historically, administering cytotoxic chemotherapy has been the domain of cancer nurses, with chemo certification. Many new agents are not cytotoxic, therefore don't require the safe handling training. As well, many targeted agents are administered to non-cancer patients by non-cancer nurses. Is there an argument that general nurses employed within HIF could potentially administer immunotherapy and targeted agents within the home? I think we need to be cautious with such an approach, so that cancer nursing is not reduced to administration of drugs alone, but the provision of whole patient care by a suitably skilled cancer nurse. Pharmacy services within our unit are also very comprehensive, so moving patients out of the day oncology unit removes that level of support for patients and, very importantly, the level of scrutiny and oversight that a cancer pharmacist specialist provides. With an ageing cancer population, specialist pharmacy input will become increasingly beneficial and needed. Private providers and industry-sponsored programs exist to deliver cancer therapeutics in the home, and depending on the length of the infusion, this tends to be a financially and patient-friendly option that we are currently exploring. But again, the provision of pharmacy oversight and other allied health services is an important consideration in this decision. The underpinning factor is whether patients want to move their care to the home environment. Whilst it may seem like a very attractive option, many patients, in my experience, do like the security of coming to the centre, socialising with other patients and having exposure to a number of healthcare professionals. At the end of the day, I haven't provided any solutions, but just highlighted the challenges that we face. But as the philosopher Voltaire once said, judge a man by his questions, not his answers, and I'm sure that applies to women as well. Thank you.
Thank you very much, Angela. You've really given us a comprehensive sense of some of the challenges. A couple of questions have come through. I'm just going to pick two for the sake of time. One question around the ADAC resources and their applicability to clinicians in other environments such as ED. Do you have a sort of perspective on that?
Yeah, look, I think they do have applicability to physicians in ED. I guess the problem is that we think, I think it's about 3% of ED, the patient population that go to ED, are actually cancer patients. So it's that issue of, it's a fairly time-intensive expectation to put on an ED nurse to undertake those EVACU modules when at the end of the day they might not see a cancer patient for weeks on end, depending when they work and whether the cancer patients come in. I'm more for developing models that prevent patients coming to ED, as everyone knows about me.
And just one last question, which also touches on some of the stuff that Graham was talking about. Do you, with the programme of bringing people in the day before for education, do you formally assess their level of health literacy as part of that?
I think that's variable depending on the nurse who's doing the education. We're about to, we've actually just got a grant from NEMIX to look at developing some sort of standardisation in the way we do educate patients. And I think that a part of that piece of work will be around assessing health literacy. But I would say that the nursing workforce generally probably don't do that as well as they could in my centre, and probably others as well.
Join me in thanking Angela. Thank you.